Welcome to EPG Pathshala on the subject Social Medicine and Community Health. I am Dr. C.P. Mishra, working as Professor in the Department of Community Medicine, Institute of Medical Sciences, Banaras Hindu University. I shall be discussing the module on National Program for Control of Blindness. It belongs to the paper National Health Programs and Policies. This module has been developed by a team comprising of myself and other experts from the different part of the country. The learning objectives that have been set for this module is that after going through this session, one should be able to state the burden of blindness in the country, describe the goals, objectives, strategies, and organizational structure of the program. Now, considering blindness is a very serious public health problem in the country, Government of India started National Program for Control of Blindness in the year 1976. It is a centrally sponsored scheme, 100% sponsoring. The goal of this program has been to reduce the prevalence of blindness from 1.4% to 0.3% by the year 2020. During the 12th five-year plan, that is from the year 2012 to 2017, blindness is categorized under the Program for Disability Prevention and Rehabilitation. Now, burden of blindness. Burden is a term that refers to the magnitude as well as its consequences. Of the globally estimated 37 million blind persons having visual acuity less than 3 per 60 by 60, 7 million are in India. As per the survey by National Program for Control of Blindness and WHO and Government of India, prevalence of blindness has reduced over a period of time. The table 1 given tells us that in 1976, the prevalence of blindness in the country was 1.49%. And this was based on the survey conducted jointly by the National Program for Control of Blindness and World Health Organization. In the year 2002, it was 1.1% based on the rapid assessment conducted by Government of India, and in the year 2007, it was 1%, again by rapid assessment Government of India. And it is said that by the year 2020, the prevalence of blindness in the country should be around 0.3. That is the target set to be achieved by the year 2030. Now, if you look in the table 2, the main causes of blindness in India is given. The cataract is by far the most common cause of blindness in our country. It accounts for 62.6%. Refractive errors 19.7%. Corneal blindness 0.9%. Glaucoma 5.8%, surgical complications 1.2%, posterior capsular opacification 0.9%, posterior segment disorders 4.7%, and other conditions together combined to contribute about 4.19%. Now, Vision 2020, the right to sight launched by WHO and a task force of international NGO in Geneva on February 18, 1999. 5 basic strategies to combat the burden are disease prevention and control, training of personnel, strengthening the existing eye care infrastructure, and use of appropriate and affordable technology, and mobilization of resources. Goal under National Program for Control of Blindness is to reduce the prevalence of blindness to 0.1% by the year 2020. Objectives of the National Program for Control of Blindness in the 12th plan. The 12th plan has given a very concerted effort to tackle the problem of blindness in the country. And under the program, National Program for Control of Blindness, a number of objectives have been set. The first objective is to reduce the backlog of blindness through identification and treatment of blind at primary, secondary, and tertiary levels, based on assessment of the overall burden of visual impairment in the country. The second objective is to develop and strengthen the strategy of National Program for Control of Blindness for eye health and prevention of visual impairment through provision of comprehensive eye care services and quality service delivery. Third, to strengthen and upgrade regional institutes of ophthalmology, RIOs, to become center of excellence in various specialties of ophthalmology. The fourth objective that has been set under National Program for Control of Blindness in the 12th plan is to strengthen the existing and develop additional human resources and infrastructure facilities for providing high quality, comprehensive eye care in all districts of the country. By comprehensive care, we mean preventive, promotive, and curative care and also rehabilitative services. The fifth objective is to enhance community awareness on eye care and lay stress on preventive measures. The sixth objective has been to increase and expand research for prevention of blindness and visual impairment. Last, the seventh, to secure participation of voluntary organizations, private institutions in eye care. In order to tackle the problem of blindness in the country, 4-pronged strategy of National Program of Control of Blindness has been envisaged. The first strategy is to strengthening service delivery. Second strategy is to develop human resources for eye care. And third is promoting outreach activities and public awareness. And last but not least, developing additional capacity for provision of comprehensive eye care. Now, a number of definitions has to be understood in context of National Program for Control of Blindness. Visual impairment is when a person has sight loss that cannot be fully corrected using glasses or contact lenses. There are two main categories of visual impairment: being partially sighted or sight impaired, where the level of sight loss is moderate, and severe sight impairment, that is blindness, where the level of sight loss is so severe that activities that rely on eyesight becomes impossible. Blindness is defined by National Program for Control of Blindness under following headings. First, inability of a person to count fingers from a distance of 6 meters or 20 feet. This is known as called often technical definition. Vision 6 by 60 or less with the best possible spectacle correction. Diminution of field of vision 20 feet or less in the better eye. Economic blindness, that refers to inability of a person to count fingers from a distance of 6 meters or 20 feet. That is also the technical definition. Social blindness, vision 3 by 60 or diminution of field of vision to 10 degrees. Manifest blindness, vision 1 by 60 to just perception of light. Offshoot blindness, no perception of light. Blindness, different categories of blindness have been identified and described. Curable blindness refers to that stage of blindness where the damage is reversible by prompt management, like cataract. Preventable blindness refers to the blindness that could have been completely prevented by institution of effective preventive or prophylactic measures, like xerophthalmia due to vitamin A deficiency, trachoma, glaucoma. Avoidable blindness, that is the sum total of preventable or curable blindness together. Now, after discussing the basic concepts related to the blindness, we will be discussing organizational structure of National Program for Control of Blindness, which has been launched as a centrally sponsored program. At the central level, state level, district level, we have mechanisms. At the central level, there is a National Program Management Cell in Directorate General of Health Services or Ministry of Health and Family Welfare. At a state level, we have a State Program Cell and a State Health Society. At district level, we have District Health Society. Now, composition of State Health Society. Secretary Health is the chairperson or chairman. Director of Health Services, vice chairperson. Representative of the Finance Department, member. One reputed expert in the field of ophthalmology as a member to provide the technical inputs. One member of the non-governmental organization and nominee and representative of Ministry of Health and Family Welfare as a member. Joint Director of the National Program for Control of Blindness as the member secretary. A number of functions have been ascribed to State Health Society. The first and foremost function is to monitor and supervise implementation of National Program for Control of Blindness in the state. Monitoring and supervision is important for components because that tells precisely in which direction the program is going on and how to improve program by doing midterm corrections. Release and monitor flow of funds, expenditure and functioning of District Health Society. Then implement training and IC activities in the state. Recommend granting act to the non-governmental organization for non-dependent grants. Funds for District Health Society will be released to the State Health Society. The releasing pressure with the central government to the central government can focus more on the other technical inputs. District Health Societies are the nucleus of the entire activity of National Program for Control of Blindness. District Health Society is the program implementation unit at the district level, which coordinates different agencies and monitoring mechanism implementation by pulling all the resources available. National Program for Control of Blindness has several constraints. A number of constraints have been identified in the 12th plan, and attempts have been initiated to take care of this. The first and foremost constraint has been unequal distribution of eye surgeons. Equal distribution of services and equal distribution of human resource desired for optimum dividend. The first and foremost constraint that has been identified in National Program for Control of Blindness is unequal distribution of eye surgeons. It varies from 1 in 20,000 in urban areas to 1 in 250,000 areas. In 12th plan, attempt is being made that additional eye surgeons be provided and 250 eye surgeons sanctioned in the 11th plan continue. Upscaling the number of surgeons, all the 60-50 districts, hospitals on contractual basis. Insufficient number of paramedical eye care personnel. For efficient functioning of National Program for Control of Blindness, it is desired that the ratio between eye surgeons and paramedics should be 1:3 to 1:4. Unfortunately, there is insufficient number of paramedics eye care personnel, much less than the desired level. In the 12th plan, it has been envisaged that additional 425 ophthalmic assistants at district hospitals and primary centers, regional centers should be recruited. Personnel on contractual basis could be appointed. These are ophthalmic surgeons in all district hospitals, ophthalmic assistants in all district hospital and PSCs and regional centers, eye donation counselors in eye banks under government sector and NGO. Why eye donation counselors are important? Because if eye banks has to function in a proper manner, then people need to be educated about eye donation, because there are there are many confusions in the mind of the people. So therefore, counselors have to play a very significant role. Data entry operators for all the districts are that. Driver assistants, one for each district is needed. Or suboptimal coverage by government institutions. Unfortunately, the services regarding ophthalmic care are not uniformly distributed throughout the country. And geographically remote and socially, economically backward populations remain unserved. Therefore, as per 12th plan, the strategies are: number one, multi-purpose mobile ophthalmic units to be introduced at the district level to reach the remotest area. Construction of dedicated eye units in district hospitals, particularly in the northeastern zone, Bihar, Jharkhand, Jammu and Kashmir, Himachal Pradesh, Uttarakhand and a few other states where dedicated operational theatres are not available. Now, in order to address efficiently National Program Control Blindness Program, we have to take care of other problems besides like corneal blindness, glaucoma, diabetic retinopathy, along with pediatric ophthalmology and low vision, which have received lower priority till date. Most of the time, the program was prioritizing only on cataract operation. As per 12th plan, to make National Program Control Program more comprehensive, assistance of eye diseases other than cataract was initiated during the 11th plan. 11th plan has shifted its focus only from cataract to other areas. It is proposed to continue the same initiatives during 12th plan as well. Now, National Program Control of Blindness emphasizes that public awareness is a key input. Even for, say for example, vitamin A coverage in 0 to 6 year children is important because that is a preventable blindness. We can prevent blindness associated with vitamin A deficiency. Lack of public awareness about green leafy vegetables, about dietary diversification at different stages of life and different phases of life still prevails in our country. So, rural, illiterate and underprivileged population are fully aware about various interventions that are available to restore vision of the blind. Many people are not aware about the facilities, the services that are being rendered by primary, secondary and tertiary institutions in our country as far as eye care is concerned. People are only aware about cataract and other diseases which are contributing to blindness. Many people are not aware, and therefore a mechanism of awareness building, not only about the diseases but also the services that are available, so that people can utilize these services whenever they need it. As per the 12th plan, information, education, communication activities will be intensified through print, audiovisual media, as well as multimedia and interpersonal counseling for free cataract surgery with intraocular lens, free spectacles for school children and old persons, diagnosis and treatment of corneal opacities, diabetic retinopathy, glaucoma, and stroke. Interpersonal counseling through health professionals is very important because that induces behavioral change in the people to opt for services. Focus area and 12th 5-year plan for National Program for Control of Blindness, in line with Vision 2020, the cause of avoidable blindness to be concerned upon are cataract, number 1. Number 2 is refractive error. Number 3 is low vision, corneal blindness. Other emergency diseases like glaucoma, diabetic retinopathy and cause of childhood blindness like cataract, screen, amblyopia will be also addressed. Initiatives under National Program for Control of Blindness during 12th plan, that is from the period 2012-2017 is 1. Development of mobile ophthalmic units in northeastern states, these states difficult terrains for diagnosis and medical management of eye diseases, especially in remote and underserved areas. Distribution of free spectacles for near work to old persons suffering from presbyopia. Involvement of private practitioners in suggested block and raised labels. It has been observed that for outdoor basis, majority of the patients are going to the private sector. and our major concern is to provide services to the people of India. And therefore, involvement of private practices in this program becomes very important. All diabetics should be referred for regular fundus examination from medicine departments across the country, and necessary eye educational material be developed. Delink all resource centers and hospitals, medical college of Delhi from Delhi State University, and it is indicates that rupees 80 lakhs be funded directly from the center for this purpose. Rate contract is to be established in the central cell in National Program for Control of Blindness, and a technical committee to be set up at the central level for specifications of equipment. Efforts will be made for the maintenance of ophthalmic equipment supplied in Regional Institute of Ophthalmology, medical colleges, district and sub-district hospital, primary health centers, and vision centers. All efforts will be made that the instruments that are available, they are in working order so that services can be delivered in the best possible way. Strengthening of existing regional institutes of ophthalmology on priority and link the medical colleges for training and development of setting up more regional institutes of ophthalmology in the different parts of the country. Eye banks should be strengthened and should be established in all the regional institutes of ophthalmology. Now, 12th plan is very well planned, and it has kept certain outcomes in the area of vision improvement, particularly related to blindness. Now, physical targets in the 11th plan and 12th plan is compared here. The cataract surgery, the envisaged figure was 300 lakhs in the 11th plan, and it is proposed that in the 12th plan, 350 lakhs cataract surgery will be performed. 90% operation will be by intraocular lens implantation. Spectacles to school children to take care of refractive errors and so on. The target was 15 lakhs in the 11th plan, and it has been enhanced to 50 lakhs in the 12th plan. Collection of donated eyes, the target in the 11th plan was 2,65,000. It has been enhanced to 3 lakhs during 12th plan. The spectacles for near work to old persons, there was no target in the 11th plan. Kept at 10 lakhs in the 12th plan. Now, in order to achieve successful evidence, there should be an accountability framework, there should be a monitoring framework, and National Program for Control of Blindness has taken into account this. The state program officer, the district health society, shall inspect the work done as and when required, and shall also obtain monthly report from the non-governmental organizations of the work done. Random checks will be also performed to assess the validity of reported data, status of follow-up, provision of glasses and patients. Standard cataract surgery records. I repeat, standard cataract surgery records for operation performed will help in providing relevant information about visual outcomes and other quality parameters. Periodic review should be undertaken by district health society to assess the progress done from different provider units. Involvement of voluntary organization in the National Program for Control of Blindness is desired, and a number of areas has been identified for this purpose. National Program for Control of Blindness aims to address issues leading to blindness through public-private partnership. Focus on providing services in rural, tribal, and difficult areas by providing non-recurring and recurring grants for developing eye care infrastructure. To provide appropriate eye care services. Services will be brought close to the people so that they can use it efficiently. The program has made a substantial outflow of money so that the necessary support can be extended for the successful outcomes for the program. The provision of rupees 2,506.9 crores have been approved for implementation of National Program for Control Blindness during 12th 5-year plan for activities up to the district and below hospitals. Now, just to conclude, that National Program for Control of Blindness was initiated in the year 1976, and all the major actions were directed from primary, secondary, and tertiary institutions for their strengthening, for providing necessary support, for evolving mechanisms so that the program can be taken well. It is realized that only confining to cataract surgery is not adequate, because blindness is caused by so many other conditions. Refractive errors, particularly for that school program, has been emphasized. In old days, besides cataract, there could be cases of diabetic, cases of glaucoma, and other disease conditions that has to be taken into account. Although preventive causes of blindness are inbuilt in the national programs, like due to 6-year children are getting vitamin A deficiency, there is an emphasis on dietary diversification so that vitamin A consumption increases in all the age groups. But since the life expectancy is increasing, cataract cases will be always on rise. Non-communicable diseases are on rise. Therefore, hypertension, diabetes, and so other conditions will give rise. And therefore, it becomes important to initiate mechanisms so that people are screened for any complications related, ocular complications related to the two conditions. Necessary capacity to strengthen district healthcare units in provision of eye care has been started. It has been simply realized that the services distribution is not uniform throughout the country. There are many pockets where ophthalmic services are at very low level, manpower position is very distorted, and therefore it is envisaged that in the public-private partnership mode, we should involve mechanisms so that infrastructure provision of eye care is available in different parts of the country, and manpower is available, particularly ophthalmic surgeons are available, and for their optimum functioning, there should be paramedics also, and for that purpose, it is envisaged that where these services are not available, the number of seats have been, number of positions have been increased, and contractual mode of operation has been also envisaged. Sufficient financial outlays have been made during the 12th plan so that necessary inputs in terms of ophthalmic instruments, in terms of intraocular plants be made available to the people, and spectacles and glasses may be made available to the school children and geriatric subjects, so that the problem of this blindness can be taken care of. Now, in spite of all these efforts directed towards primary prevention, secondary prevention, there will be cases where we will be needing services of eye banks. And it is envisaged that eye banks should be protected. Though more focus is being provided on primary prevention and secondary prevention, but in spite of that, we will be needing eye banks because of taking care of many problems which cannot be managed at secondary level. And in order to enhance voluntary donation of eyes, these counselors are being brought into the system so that more people are coming forward to donate their eyes, and so that we can provide the tertiary care, that is trustee prevention to the people who are needing eye services by refreshing their cornea and so on. So a comprehensive approach has been developed for the control of under the National Control of Blindness program, and it is expected that we'll be moving forward to achieve the goal set 2020 vision to sight. Thank you for visiting NPCB.